Renal replacement therapy. Various forms of renal replacement therapy can be used to remove excessive fluid and solute to improve electrolyte balance and remove other nitrogenous waste products. Indications. The most important indications for initiation of renal replacement therapy are fluid overload, hyperkalemia, and metabolic acidosis. Other signs of uremia, such as a change in mental status, pericarditis, or gastrointestinal bleeding, should also prompt initiation of renal replacement therapy. However, a very important and sometimes difficult decision to make is whether renal replacement therapy should be initiated at the first sign of persistent oliguria or a rise in creatinine, especially since the latter tends to lag behind the extent of renal dysfunction. Studies suggest that early and aggressive dialysis before the patient develops signs and symptoms of renal failure and before a marked elevation in creatinine occurs might improve outcomes. Certainly, when marked oliguria is present early after surgery in a patient with significant fluid overload, a delay in initiating renal replacement therapy may lead to respiratory compromise and prolonged ventilation with its attendant risks, as well as other complications commonplace to ventilated, sedated patients in the ICU. It is hopeful that an early aggressive approach will have some impact on the high mortality rate associated with postoperative renal replacement therapy, which is even greater in patients with concomitant cardiac failure and when gastrointestinal complications develop. An additional consideration in patients with moderate renal function, serum creatinine more than 2.5 mg deciliter, is use of prophylactic preoperative dialysis. Several studies have demonstrated that this reduces the need for postoperative renal replacement therapy with a reduction in overall morbidity and mortality. The most common forms of renal replacement therapy used in cardiac surgery patients are those of intermittent hemodialysis and continuous veno-venous hemofiltration. Selection of a modality depends on the indications for its use, whether primary for volume or solid removal, and the hemodynamic stability of the patient. Both modalities are associated with comparable outcomes such as recovery of renal function and mortality. Now I will show you this table, techniques of renal replacement therapy. If the patient has unstable hemodynamics, hemodialysis is not good, but other slow continuous ultrafiltration, continuous veno-venous hemofiltration, continuous veno-venous hemofiltration with dialysis is good. Contraindication to heparin, everything is it can be, but hemodialysis more can be. Vascular access problems, every technique. Volume overload, every technique. Hyperkalemia is not for slow continuous ultrafiltration. Severe uremia is not for slow continuous ultrafiltration. Respiratory compromise can be for every technique. Now we are going to discuss intermittent hemodialysis. Principle: solute passes by diffusion down a concentration gradient from the blood across a whole fiber semi-permeable membrane and into a dialysate bath. Some solute is also transported by convection resulting from a difference in hydrostatic pressure. Indications: intermittent hemodialysis is indicated for the management of hyperkalemia, acid-base imbalances, fluid overload, or a hypercatabolic state in the hemodynamically stable patient. It is the most efficient means of removing solute, urea, creatinine, and correcting severe acid-base abnormalities. It doesn't obligatory remove fluid, but can be combined with ultrafiltration to achieve this goal. Access: standard intermediate hemodialysis is performed using a single 12 French double lumen catheter such as the Niagara sleeve catheter, placed in the interjugular or a subclavian vein, although the latter is more likely to be associated with venous thrombosis. Placement in the femoral vein may lead to a lower extremity venous thrombosis but can be used for very short-term dialysis. To reduce the risk of infection in patients requiring more expanded periods of dialysis, a double lumen perm cath or hemodialysis catheter can be placed in the internal jugular vein and brought through a subcutaneous tunnel. Subsequently, a fistula can be created for permanent dialysis. When recovery appears unlikely and the fistula is being considered, the arm vessels on one side should be protected from use as much as possible. Technique: intermediate hemodialysis is performed over a 3-4 hour period and usually provided at least 3 times per week until renal function recovers. The blood is pumped into the dialysis cartridge at a rate of 300-500 milliliter minute, while the dialysate solution is infused at a rate of 500 milliliter minute in a direction concurrent to blood flow. Also, heparin is commonly used. Heparin-free hemodialysis is possible in patients with bleeding problems or heparin-induced thrombocytopenia. Limitations: circulatory instability with hypotension from a blunted sympathetic reflex response to hypovolemia is the most common complication of hemodialysis, especially if large volumes are being removed in a short period of time. The rapid removal of solid will reduce plasma osmolarity, prompting water movement into cells, exacerbating the depletion of extracellular volume. This problem has been mitigated to some degree by use of biocompatible membranes, bicarbonate baths, initial high dialysis sodium, cool temperatures, and volumetric control during dialysis. Colloid or blood transfusions and hemodynamic support, usually with alpha agents or peroximidodrine, are frequently necessary. Therefore, hemodialysis is best avoided in the hemodynamically unstable patient. Dialysis machines are complex and costly and require special expertise.